All right, good afternoon, everyone. Just letting people in from the waiting room. We appreciate everyone joining us. This is a great group. Thank you so much. We already have our slides ready to go. Going to have a great discussion. So just to orient everyone, we're in session 4 of our series focused on individuals with intellectual and developmental disabilities. And in West Virginia, particular focus within our behavioral health system and processes. So we appreciate you joining us. I'm going to be putting, my name's Leslie Cottrell. I'm going to be putting some things in the chat as we go. And in fact, to get us started, 2 things. If you don't mind to put your name and your affiliation, that would be great. That would tell us who is here and give us a little bit of idea of who's joining us. I see some people with their cameras on. Thank you so much. That leads to friendly conversation, although you don't have to do that. It's quite all right. Totally get it. Please make sure then on the side as our presenters are talking that your background's muted. But having said that, if you have any questions, feel free to raise hand, put it in the chat. We will also include some time to stop. And the whole point of this echo session is to think as a group, what would you do in that situation? What resources do you know about that we could also share? That's the whole nature of the game. So with that, I'm going to turn it over to our first speaker, Dr. Lauren Swagger. And she's going to be presenting our didactic piece. And then she'll introduce, sorry, I have things going on. She'll introduce Elma in more detail, and each of them can give more background. Last thing, remember we have closed captioning available. Please utilize that. If you run into any issues with any of those services, let me know through the chat and we'll get it going. Okay, with that, Dr. Swagger, I'll turn it over to you. Thank you.
Hi, everybody. Thank you for having me today. Today, we're going to kind of talk about what the official title is, the difference between behavioral and mental health services. And I think you'll learn pretty quickly that I'm actually not a real fan of those terms, but that is how services are labeled. So we're going to call it that. But I think for me, and I'm going to highlight this in the discussion today, is especially in looking with individuals with IDDD and other developmental disabilities, it's kind of a more appropriate, I guess, way to sort of think about this is what is a developmental need and what is a mental health or psychiatric etiology of a symptom or behavior. And I think, although we'll be highlighting differences in approach, I think, and Elma's case will probably highlight this, is the importance of both in our populations is really strong. It's just a different framework or a different way to kind of approach different things, so that we think about it differently in terms of how we think about service needs. But for most of our clients and our patients, it's really a both and, I think, more than a separation or this or that. So we'll dive right in. And for me, this is a very natural transition because my background is really with children, and the developmental needs of children extended to the developmental needs of adulthood across the spectrum too. And so this is sort of an outline of kind of how I've approached those different needs in assessing people. As always, I love to be interrupted. I think questions are awesome. So please do not hesitate to come off mute and frankly interrupt me or drop something in the chat if I can clarify anything. So here are some of the objectives that we're going to talk about today, really looking at behavioral etiology, trying to understand the etiology of a behavior, and then using that etiology to really connect to treatments that work and treatments that don't along these differences in symptoms. And I'm going to start with just some definitions, because from some of these definitions of either psychiatric or intellectual disability language, we see where some of the treatment targets come from. And so, although most of you on this call are very well informed, the term intellectual disability has largely replaced and been considered the most appropriate term for quite a time. And that is the language that's kind of used in the DSM diagnoses now, and I'll show you what those say. But developmental disability, which we often use, is actually kind of a broader term with more legal definitions. So it's important understand that sometimes the terminology, some is really from legal statutes, some are from medical statutes, and sometimes they aren't always the same. But we really, as most of you on this call know, we really want to use person first language. So these are not these are people with intellectual disabilities or people with developmental delays, not just someone who has a label. People are not their labels. So we want to do that. And that's been a big shift in the psychiatric literature as well. So I want to go into what the definition of an intellectual disability is, because it is the only diagnosis in the psychiatric manual that actually requires a test. That is a test of intellect, or an IQ test. And there are different variations of that, but it starts with identifying that there's some significant standard deviation difference, or 2 standard deviations below what is the normative. And the language around intellectual disabilities and developmental disabilities has really tried to get away from numbers and really look at symptoms and functioning. And so typically people labeled that IQ difference as about below or 70. However, an IQ below 70 alone does not meet the full definition of intellectual disabilities. And it really is trying to see that you should get away from the idea of numbers altogether, and again, really look at function. So when we think about what intellectual functioning is or cognitive functioning is, it's really the ability for someone to have problem solving skills, reasoning skills, abstract thinking, and judgment. It might include academic learning that they've accumulated through schooling, or just life experiences and trial and education. And this is developmental. And so for adults and kids, this is a process that you can gain or lose intellectual and cognitive constructs throughout your lifetime as a variety of exposure. And sometimes people that have had significant psychiatric symptoms or illness on top of intellectual symptoms can have changes in their cognitive abilities because of that illness or other medical illnesses as well. So while in theory, we like to think of IQ or intellectual functioning as a fixed entity, it really can vary and change over time. But this is the cognitive piece. Now, the actual more important piece to thinking about treatment and to fully meeting is to not just have evidence of a numeric score below standard deviation, but to really have struggles that show that you're having problems with adaptive functioning, or how you're utilizing those skills functionally in your day-to-day life. And so when people apply for the waiver or for services, there actually needs to be some type of adaptive functioning or scoreable way about what their skills are. And sometimes people refer to these as sort of like your ADLs, your activities of daily living, adaptive functioning. It has a lot of different names, but this is really looking at a person's interrelatedness in their world and their ability to have interactions. And it's broken down into things like communication. How are their communication skills? This could be, from their words, but it could also be actions. It could also be pragmatic speech. It could be ability to read social cues. There can be a lot of aspects of that. And that also goes into social skills. That's how you're interacting with others. That can entice communication. But other things like your just ability to take care of yourself, your dressing, your eating, your daily day-to-day ability to shop or manage money, and just how you're functioning in a work or school environment, all is sort of included in that. This is where I will point out that, I'm not going to go through the criteria for autism per se, but with an autism diagnosis, you can have an accompanying intellectual decline or not. It could be normal, but when you see an individual with autism, the difference in the definition of autism and intellectual disabilities from a functional standpoint is that in autism, the communication and social skills specifically are much below the other skills. With intellectual disabilities, in general disability terms, you may see decline equal to what you would expect sort of with their cognitive abilities, but in autism, there's some extra delay in the social and communication skills, even below what's expected.
Can I ask a question?
Yeah, I love questions. Go right ahead.
Is there ever a potentiality for separate tests for that? I am finding that, first of all, autism is through the roof, right? But kids that qualify for this program at 3 to 10, give or take, probably past that point shouldn't continue to qualify, yet somehow do. Because
You're correct.
I honestly don't know why. Because there are a lot in my experience that would be perfectly able to be quote unquote a productive member of society, but aren't allotted the ability because they're on waiver.
Yeah, so I'm gonna answer that a couple different ways. So I do think, I think it's really important to understand sometimes that the IQ tests are just a moment or a snapshot in time when they're done. There's a lot of things that can interfere with that. And there's a lot of treatment or interventions that can change someone's performance along these things. So when you're talking about kids that are developing anyway, there should be points in time where the need is reassessed because you will it is absolutely true. You will see kids gain 30 IQ points, and it could be a variety of different things from the intervention provided to they finally acquired language, and it wasn't so much an intellectual deficit as it was their ability to show their knowledge. And then sometimes on these adaptive scales, and this is one of I think the most challenging thing is you really have to know the person filling them out has to really understand the questions being asked of them too, right? I've seen people report functional scores that are way higher just by virtue of not having a standard too. So while I can't answer how the waiver works specifically in reassessment, you're absolutely right that it's not unusual that you can see massive
Any
changes, declines as well in things for a variety of reasons. But
any test that solely relies on somebody else who's dependent on that check that comes in,
yep. Yep.
also makes an impact. That I have an autistic son, and I know when I needed to get him some services, before he could actually communicate, I made sure he was tired before we went and did any tests because I knew a tired son is not nearly as productive, and I needed those testers to see this is how you get him more often.
Yep.
But if the evaluators don't have the ability to spend the time with the child to truly see what they're capable of or not capable of, how are we getting true diagnoses and putting forever diagnoses on kids that maybe just need a little bit of help until they're 10?
Yeah, well, I could not agree with you more. I think that is a marked limitation of the system. And some of it's because we don't have enough providers or people that have that ability or access to follow people forward. Because all of these are also diagnoses that change, right, and evolve.
Right.
And you want to see them evolve and get better. And there's some fallacy just in a system that has to keep showing illness, right? I mean that's a systemic problem. But you're right. And you can have a really bad day and score terrible. You can have a really good day and score better, or the person might just see you at your 10 good minutes. And so these really high quality diagnostics are decisions made over time with multiple points of collateral and reassessment. And I think you also highlight the point of money. I mean, money is an issue. But money drives a lot of things, but it doesn't always equate to what people need for success either. And when you have limited resources, it's easy to have number cutoffs that don't always match true health diagnosis either. So again, that is quite a fallacy, and that's why actually at least the DSM has tried to get away from these hard numbers and really look at things over time, because a lot of services were getting denied based on hard number cutoffs that really were kind of going away from that. So when you really read the criteria they really have tried to get away from using the absolute cutoffs and numbers. Same in the school system. Do they still talk about them? Sure. But that's just not a full picture of an individual.
Right.
And it also is kind of a challenge because, you know, cognitive issues as related to intellectual disabilities are really supposed to be things that start early, right, in childhood or adolescence. When you can develop a developmental problem for a variety of reasons, but the technical correct term for those things would be something like a neurocognitive disorder instead of a developmental or IDD disability. But things like a traumatic brain injury or a stroke or something that causes a significant loss of cognition that would be acquired later would be kind of more like an acquired neurocognitive problem. And there have been hard cutoffs used for those as well. But in theory, a true intellectual disability, developmental disability is one that starts through from birth and is not acquired. And so there is a difference in the diagnostic paths of those. Again, and sometimes it's very hard to get the history to know when you just see someone at X point in time and you don't have the history of their early development or the trajectory of their needs. It's sometimes very hard to get the label right. And so when we talk about this is again where we really have tried to get away again back to functional analysis, but you see in all these examples they're going back to the old language of the numbers. And so when you're really trying to think about the severity of an illness or the severity of a symptom, you want to link it back to their functional abilities. What would you expect they could achieve? And so there are these qualifiers of mild, moderate, severe, profound intellectual disability that are labeled, and they're supposed to be linked kind of to their functional abilities. And so you'll see that, you know, in the old language, people kind of viewed mild as 50 to 55 up through 70 with this idea that they could live independently. And so this is kind of a challenge about, well, how do you live independently if you don't have the resources of developmental support alongside your IQ so that you can gain them? And so this is also where the expectation may be that they cognitively are able to give those skills, but if you don't have the resources to build their independent living skills, you're going to fall down in your abilities from what's expected. And so many of these original definitions implied that they were getting the services to acquire their developmental levels, and that's not always the case when we struggle to find resources to support people. So at every moment in time, I sort of believe we have to understand where someone is cognitively, but we also have to really think where they are developmentally. If they're making the gains that you would expect that they would, are they not making gains because of some other illness? Are they not making gains because they're not getting those services to build those skills? That is a very, very challenging question when we know how limited resources we have sometimes. This kind of goes back to one of your questions too, and another kind of category that exists in the DSM is actually one for children under 5. And I just throw that out there because this is in those early kids when they, you know, it's hard to test a kid under 5. There are IQ tests for kids under 5 actually, but they have such rapid needs and rapid development. There's a lot of environmental and nutritional and emotional needs that are very key. That there actually is a category of global developmental delay for kids under 5, where they're really struggling to meet their milestones across many levels, from physical to cognitive to other health health delays. And this is one that is, I think, important to point out that with really intensive early intervention, many of these kids don't go on to meet IDDD diagnosis as they would, and we forget that sometimes. And this is, I think, the power of services and developmental treatments and support, because you can, with intensive interventions at helping communication or OT, PT, speech, social skills, engagement, attachment skills, emotional work, you really can uh, show, as I would say, neuroplasticity and growth of those neurons with a rich environment to help people grow and gain in skill. And so people do outgrow their diagnoses. It is well known that even people with early diagnosis of autism or global developmental delay with that intensive intervention may not meet criteria any longer for those services. Does that mean they don't need anything? Absolutely not. But that's part of what we hope to see, and we know we do see with treatment. I think it's also important to kind of, this is where the medical stuff I think also really overlaps. It's also helpful to have a sense of the etiology of the presentation. What if there is a reason may have contributed to the etiology of these cognitive and developmental symptoms, because they may allow us to predict future needs, future medical needs, because many things, especially genetic syndromes, may have expected patterns or things that might develop later we want to be mindful of and monitor. Environmental effects can change presentations as well. So there can be a lot of things, from things that happen before birth to during the perinatal period, whether it's a toxic exposure, a vitamin or nutritional deficiency, a birth injury or some type of insult, or even after birth, if there's a hypoxic injury or health infections that might be contributing, because all of these things, and it's a very overwhelming slide, but all of these medical conditions do impact the health and growth of those brain neurons that help us gain our cognitive skills, and they have to be treated or managed, and even stress. Many of you have heard me talk about sort of the impact of stress and the cortisol pathways. Cortisol is destructive to neurons too. So environmental stress, high emotional intensities, or other sort of even SES needs can drive cortisol and potentially be toxic to these neurons and inhibit people's path to full acquisition of skills. But sometimes it's really important to identify some of the underlying causes because of this predictive ability. And there are clear genetic disorders that have both high risks and predictable patterns for things like autism, intellectual disabilities, and a clear psychiatric illness. And I give the example of velocardiofacial syndrome, which is a known genetic deletion syndrome of 22q11. If that's identified as a cause of delays, it actually is one that really speaks to the fact that they also have a very, very high risk of a psychiatric disorder, with almost 25% of people that have this specific deletion not only having a trajectory of developmental delays, but 25% have a developmental risk of becoming psychotic and having schizophrenia too. And it is a major overlap that occurs, but it's not the only one. And so I think it's important to really to understand what's a cognitive part of this picture, and what is the psychiatric piece too, as well. These are other, again, uh, sort of developmental differentials. Neurocognitive disorders all involve some degree of cognitive symptoms. Many of these also have other patterns that may be exhibited. Something like Down syndrome also is associated with cognitive decline that looks like Alzheimer's disease after people acquire to age 40. That has to be taken into consideration in their care too. And then autism, we talked about that it can occur with or without an intellectual change, but really, really highlights a much more impairment in the social and communication realms than some of the other self-care realms. One of the things I'm a big proponent of, and I'm going to spend a lot of time talking about, is many times we are called to be helpful or get people services because of behaviors. They're exhibiting a behavior, and sometimes it's a behavior of significant concern. Sometimes it's very hard to know the details, but it's really important that we approach the understanding of these behaviors in a very systematic way to really understand what the etiology of the behavior is, because behaviors can have a lot of different etiology. It could be from a mental health diagnosis or psychiatric diagnosis. It could be a developmental consideration. It could be just an environmental trigger. And so I usually am running into people that have had thousands of labels, it feels sometimes. I think I saw one child with 16 diagnoses, including their intellectual disabilities. And I think that's a real disservice. It looks messy. It looks like people were careless. It looks like people didn't really take the time to really dive in to understand what was truly going on. And so I tend to be cautious when I see all these disorders being thrown at kids to absolutely go back to, okay, what actually is the behavior that we're seeing? And let's really go back and understand what's causing it, because you will not be able to truly approach treatment until you really go back through that idea. Do I truly understand where this behavior is coming from so my treatment plan meets it? And this is where I get very specific on that terminology. Some behaviors are developmental, and some behaviors truly are medical or psychiatric. And this is really in the details of how you solve the etiology question, is to really understand the difference. So when we talk about developmental behaviors, we're really talking about a behavior that occurs because the coping skill or the developmental skill to manage it has not been achieved yet. They haven't learned how to developmentally cope with this. And so, typically developmental triggers are going to kind of wax and wane with environment, may wax and wane with environmental changes or triggers or that happen. Often, the reason they struggle developmentally is they may misinterpret the environment because of their developmental needs. Perhaps they don't understand the communication involved. Perhaps they're frustrated at the skill or expectation because of they don't understand or process it. Sometimes they're overwhelmed by sensory exposures. Um, but the behavior is occurring because whatever is prompting the behavior or before the behavior is happening in a way that they don't know or have another skill on how to respond more appropriately. And these developmental behaviors are very, very unlikely to respond to psychotropic medications. And that is something I want to spend a little bit more time on at the end, but we cannot treat developmental behaviors with meds. And if we do, we will do a disservice to our families and our kids. Now, a true
Well, and remembering that not only that, but treating autistic children who also simultaneously have a psychiatric diagnosis, and the doctors understanding that psychiatric meds on autistic individuals do not react the same
correct.
is problematic.
Yeah, and that's the whole end of my lecture, Jillian. So I'm gonna so I want to show you some of that too, because I suspect you will understand that as well. And it also is important, and I should say this again, it doesn't mean that you can't have both either, right? You can have a psychiatric and a medical and a developmental cause, and that's why treatment often requires many interventions. But a true medical or psychiatric cause is a clear underlying biological component to that. That really could respond to treatment or has a clear treatment target, and it's much less likely to wax and wane with environment. It may be more likely to be persistent. It could be episodic, but typically episodes occur in weeks or months. And medicines may actually target that. So an example of autism, maybe you can have autism and have depression. You can have autism and have ADHD. Your ADHD symptoms may respond to a medication, but your core autism symptoms and those developmental communication, social skills probably will not. And so it's important we always think about the both and with some of these. And so many of you have heard this before, but I live in the world of the ABCs, right? We do not change behaviors by understanding behaviors. Yes, I need to know what the behavior is, when the behavior occurs, how many times the behavior happens, how severe it is. But I will never, ever fix a behavior if I don't understand the A and the C. I must understand the antecedents. Maybe there is no antecedent and I need to know that, but I need to understand what is happening before the behavior, what leads up to the behavior, and if there's a cue or trigger or a stressor or a misperception of the environment that leads to the behavior.
Antecedents also are very difficult, and I think maybe more so in a 24-hour setting, and you wouldn't think it would be. But if a client has delayed
Mhm.
reaction. So like I know people who let stuff boil up, and so they'll start acting out 3 months after an event and having to figure out that that's
Have
but the
any idea
antecedent
where
really happened 3 months
Claudia's
ago.
service log is for the week of March 17th?
Yeah. And I would also say that antecedents are even broader than just that too, that antecedents can be medical. They can be um they can be, you know, differences in how you process information, like how someone and some of this may be challenged by communication events that they really it may not be that there's not an antecedent, it may be that that client struggles to verbalize the antecedent or report the antecedent with other means of communication, and some of it is going to the did we do the detective work to try to find it or not. But also it's important to understand what the consequence is. What is the behavior doing? Is the behavior having a purpose? And this is really this is a hard one because sometimes caregivers reinforce behaviors that they don't even realize they're reinforcing, right? And so we have to think about our responses to the behavior and if our responses and the environmental response is making it better or worse. I give the example of, you know, my own kid, like, having a tantrum in the store over wanting a candy bar, totally embarrassing me as a caregiver, and I hand her the candy bar so she stops. I just really taught her how to throw a good tantrum and get me to give her a candy bar. And may not have realized that she just learned throwing a fit, got the chocolate, even though that was not my intent, right? And I again, that's a simple example, but sometimes we inadvertently reinforce things. And sometimes we have to, especially when aggressions are concerned. Sometimes people use aggression to communicate. And sometimes we reinforce things like that, even though we don't mean to. And while we might do it in the short term, we have to step back and really figure out how to really understand what that looks like in the greater pattern. Um, and sometimes it's really hard to figure out, right? I mean, and sometimes this is again back to the same thing with the diagnosing. The best care, the best plan really involves someone dedicated at looking this because just because what your pattern is with one behavior may not be what your same pattern is. You always have to be that vigilant detective. Um, at each event. And so when providers change, when caregivers change, when there's not a consistent way of looking at it and people change, we lose information that can be really helpful. And so this is the hard work, right? This is the digging in, the perseverance to really figure it out. And you can't, you're right, you can't figure it out in a day or even a week. This sometimes I mean I've had some kids that have had really complicated psychiatric syndrome, and it took me a while to realize they were psychotic. That was maybe the trigger for their behavior, and I just couldn't see it. No one could see it. It just took a long time for us to appreciate what it might be. And so this is that dedication, right, to really look for it over time. And again, these is just a short list, but so many things, right? So many things can be a trigger from a sensory misperception, a loud noise, a hearing deficit. They may be perceiving the environment differently, feelings of motor restlessness. We'll talk about medicine side effects can really be something people miss as triggers. Pain, medical problems, illness. How many times have I seen people have an event and they have a fever 5 days later and they weren't feeling good, right? They can all be things that could trigger it. Seizure risk, mood changes, metabolic issues, and then there can be other things. You could be having a trauma response, psychotic symptoms, other mental health things. This list is really um key. And again, I think the point too is when you think about behavior, you have to think about the whole picture, right? So the time of day, you know, if you're noticing it happening at a certain time every day or when it happens, you know, is it really, you know, is there, you know, knowing the time, the date, the location are all things like that. And so we have to think really big with us. And sometimes again, we may not know the trigger till later. So it's not in that it's in the tracking when we look back at it that we may not see it. And so even if you don't know what it is, the importance of tracking that behavior over time can really reflect the patterns later. And I think that's something that's hard when you're in distress or you want to fix it now, to really emphasize to caregivers sometimes is, I really need you to track this so I can figure it out. I know we're not going to figure it out from one event. I think together, looking at it, we'll eventually figure it out if we keep an eye on it so we can start identifying the patterns. Because you're right, you never see them in one event. So it really is a dedicated look. That's hard, and it is frustrating to track things and not immediately know, but it is really, really key to figuring it out. I said it's always important. I always say we have to be detectives. We can't give up. And then when we talk about sort of the more behavioral symptoms, the non-psychiatric ones, we really want to think about what's the function of the behavior. Like if we know what the trigger is, well, okay, so this behavior happens. Well, what purpose does the behavior serve? You know, is the behavior that we're seeing helping someone escape something uncomfortable? Is the behavior helping us get people's attention or make our needs known? Um, is you know, we talk about rocking or self-injury sometimes. That could be just the self-stimulation, or the movement could be helping with pain or motor restless feelings, or just movement you know, or stimulation can help people calm down. And you know, so we really want to think about, you know, okay, so when this happens, what purpose does it serve? You know, if I'm being triggered by loud noises, I get somebody's attention, I get removed. Maybe it's that I was overwhelmed and it was the removal that actually helped. So how can we find a way to then help with the trigger of the loud sound before the big behavioral concern happens? Like, let's teach ways to remove or find other environments with lower stimuli before we get to the big outburst. And so one of the challenges that's really key is helping people communicate. Many times our clients and patients, especially with more significant cognitive difficulties, really struggle in how to communicate. Many are not verbal. We have to think about how we can continue to help them communicate, um, and have alternative ways to really express those needs. And I think Leslie shared some we'll be sharing some additional resources on that as well. But the reality is that while we like to, again, sort of lump and split into intellectual and developmental disabilities and mental health disorders and psychiatric disorders, there actually is a significant overlap where people have both. That's the reality. And looking at true good diagnosing, you will actually see, and there's some reasons for it that might be beyond this lecture, but there really are higher rates of true psychiatric illness in those with developmental disabilities. And there's actually higher risk of medical diagnoses too in some of them that are going to contribute to these. And so, you know, there are higher rates of oppositional behavior. I hate that word because I think it's often communication, but there are higher rates of oppositional behaviors, ADHD symptoms, mood disorders, anxiety disorders, autism spectrum disorders, stereotypic movement disorders, impulse control disorders. They all have higher diagnostic rates than in populations without an intellectual or developmental delay. So, and many of the times we have to just appreciate all of the factors are there. And we have to be detectives about what part of this is developmental and what part of this is mental health or what part of this is medical. So again, you can't escape. These are messy, but it doesn't make it any less solvable. You just have to dig in and really know our clients and understand their behaviors to solve them. Here are some rates of medical conditions associated with these things. So again, these are much higher than the normal population too. So you're gonna see them all together. It is challenging sometimes for providers to get accurate diagnoses, especially of mental health conditions. Because you know, if you have a cognitive delay, you can't fill out all the questionnaires or maybe answer the doctor's questions verbally. And so there actually is a whole sort of part of psychiatry that's looked at how do we track psychiatric symptoms in a population with lower cognitive abilities or IDDD. And there actually are some specific checklists that look at certain behaviors differently than in the traditional psychiatric world. And here are just some examples to really look at the presence of how you look at those symptoms differently. And it kind of is, to simplify what it's doing, it's often looking at things that you can assess outside of reportable stuff. So let me kind of give you some examples. An aberrant behavior checklist is kind of a good sort of thing where it's tracking things like aggression or social withdrawal, or if you can look at symptoms of depression by energy changes or withdrawal from activities that people used to enjoy that don't require the self-report. But again, it's harder because it takes some time and you have to be looking for it to think it's there. But here are some examples of specific disordered screeners kind of designed for a different population. So ultimately, when we think about treatment, we have to treat both. If there truly is an underlying psychiatric condition, like someone is psychotic, they will probably need an antipsychotic in traditional psychiatric treatments, but they also probably have needs well outside of this. And so many behaviors are both as well. Well, they may have mental health components. They may also have this behavioral component. And so I don't need to tell many people on this call, but functional behavioral assessments are really at the heart of some of this behavioral stuff, is we really have to um, understand, the behavior and the purpose and see. Now, I will say that not that sometimes, again, people get in their lanes with this, right? If you're trained in a traditional mental health realm as a psychiatrist or mental health, you might miss the developmental piece. And some people that are really trained in FBAs might miss the medical piece because that's not their. So it's really important, I think, in the training of professionals that we expand our mindsets to beyond our traditional training. I'm gonna be the first person to tell you I don't think I learned anything about functional behavioral assessments as a psychiatrist. I didn't learn this until I started working specifically with kids with developmental disabilities, and I was like, "This is great." That was not part of my normal training, and so, you have to always step back and sort of think about the lens that someone's coming from, because again, I'm gonna argue all of it's important, but sometimes people don't know what they don't know, and when we're all working together, I can tell you now when I see a really good functional behavior assessment, it makes my job so much easier. But I'll also tell you it's really hard for me to find people to do it. And so even though I know it's something I need, it's also challenging to know. And then sometimes it's the reverse. I have people that will do great functional behavioral assessments and they'll be like, we've done so many FBAs, we've tried all these interventions, and the behavior's not changing. We actually really think it's psychiatric. We need to find someone willing to help us with that part. So it really goes back to how critical collabor collaboration and multidisciplinary teams are to approach these problems, because none of us can help people in a vacuum. It really truly takes a village, and I just saw that pop up too. Absolutely, we all come from different lenses and different skills. And again, more often than not, it's not one answer, right? It's a multifactorial sort of thing that's going to require all those skill sets. So when we move into treatment, and I need to move fast, but I want Elma to get to her case. But treatment's going to encompass all of those things. We have to address the medical problems. We have to address the communication needs, the developmental needs, the social skill needs, language needs. We need to understand the perspective of people. How do we teach them skills and empathy? And we need behavioral intervention plans that can be followed. And I'm going to fly through this because I'm just talking so much. We need plans to address behavioral emergencies. And I want to highlight that because lots of times behavioral emergencies are what get everybody's attention and makes people scared to participate. But it's often really important to understand that a lot of behavioral emergencies come from the same understanding or missing some of the cues, and we only notice the emergencies and we've missed all the other work sometimes, but yet we still have to protect people and keep them safe. um I don't want to spend a lot of time on this. I can do more of this if you would like, but It is no secret that we are over medicating people with intellectual disabilities. Um, I cannot tell you while I think sometimes pharmacotherapy is really important, lots of times people are giving medicines for things that haven't already had the behavioral work done to understand it. And sometimes I see sedation being more of a goal than a true functional correction or target. And so there also is a lot of things to recognize that medicines that are used to treat psychiatric illness have enormous side effects. And people with intellectual disabilities are actually more likely to get those side effects. And I cannot tell you how many times in my career I actually have thought the side effects was the antecedent of a behavior because someone was constipated from the medication, someone was having akathisia from the medicine, someone was fighting sedation from a medication. And so never forget that being a zombie or being zombified or sedated actually will worsen your behavior 100% because it's a terrible, awful feeling. And we need to make sure that that's not the goal of medication. But all too often it is. And then we forget to reassess that the side effect may be part of the problem. So I'm gonna let Elma take over. I apologize, Elma, I did not give you as much time as I promised, but I think your case is great, and I'm gonna turn it over to you.
Thank you. My name's Elma. Our case today is a 33-year-old male. He's the middle child. He has an older brother and a younger sister. His parents are still married. He did well in school academically, and he had just sinus and stomach issues, otherwise healthy. His diagnosis was autism spectrum disorder and schizophrenia. When he came to us, I was working in a long-term structured residence, and it was 14 individuals in the home. We had dual diagnosis with mental health and IDD, and mental health and substance abuse. He was our mental health IDD. He was very socially awkward. He had no friends, no job. He was living with his parents, and a lot of the people at the LTSR thought he could not have autism and schizophrenia at the same time. However, 30% of children and adolescents with child onset schizophrenia have comorbid autism spectrum disorder. So the goals that he wanted for himself was to keep from self-harming, live on his own, develop friendships. His barriers were social and communication deficits and treating the mental health disorder. So what areas or domains of functioning would you seek assistance for with this case?
Well, my first question is, are those his goals or is that somebody else's goals for him?
Those are his goals.
So he's able to articulate that.
Yes, he's almost Asperger's.
Okay.
He's very high functioning.
And those, by the way, those domains of functioning refer back to Dr. Swagger's slides, and they're right in that sub bullet: communication, social skills, personal independence at home, school or work functioning were some of the main ones. Any of those?
I have to ponder the whole conversation before I have it.
His family did very well for him. As he was a child, he had many wraparound services. He had behavior management, and I think that's why he didn't have a hard time making the friendships and stuff, is because his family was all the time saturating him with positive supports and teaching him the ways that it should go.
Elma?
Is the member able to communicate what the schizophrenia does to him?
Yes, he would say that the voices in his head would tell him to hurt himself. So he would cut himself. He would cut his wrist. One time they told him to kill himself.
Is he compliant with his meds?
He is now. Yes, he is now.
And does he articulate that the meds do help him and that the voices don't talk to him?
He says that they're still there, but they're not as bad, and he knows that they're not real now, so he doesn't pay any attention to them.
So is he getting in the community to be able to access different people to even potentially make those friends that he is his goal?
Yes, he actually, he's 40 years old now. He actually lives alone. He's holding down his own job, and he does have friends. So he's doing really well. He's staying on his meds. So I'm very proud of him.
Elma, in terms of the process, so now it seems like he can recognize the voices, like you said.
Mhm.
How did people help him get through that transition until he could recognize that? What, like we have antecedents, behaviors, consequences. What did that look like? Were you around at that time when he was still trying to figure that out?
No, when he came to us, he already knew.
Okay.
Yeah, he went through all of that stuff when he was in school. He went up to the teacher the one day and said that somebody in his head was telling him to cut himself, and he had scissors and was going to cut himself. And they did functional behavior assessments. They did all kinds of assessments and things, and they found out that he was actually schizophrenic and hearing the voices.
Was
As
he
long as he took,
always in West Virginia?
no, this case is out of Pennsylvania.
Ah, that sounds like they might have some amazing programs that allotted for more time. Because it sounds to me like even though he had struggles, he had a good support system, knowledgeable parents that advocated for him and were able to help teach him to articulate those things.
Yes.
So for my autistic son, who is an adult and definitely a borderline kind of guy, I can see where if he had had a different set of parents, his outcome would be very, very different. And having those preventatives in the beginning and somebody who understands and has the patience to work with them is invaluable. And it is something that the state of West Virginia is hands down lacking in the resources of.
I agree.
That the mental health crisis is a crisis, but the drug crisis is a real thing. And it's also a cash cow. And because it's a cash cow, everybody is coming out of droves for IDD and going to the drug population, and it's leaving us with no resources for these members. And there were already very little resources to begin with.
Right.
So real quick, Jillian and Elma, I'm sorry to interrupt you, but so knowing outside of Pennsylvania having better services than us, how do we start to implement better services? So I think the last three questions are giving us the skills or having us start to think about, based on our different roles, what knowledge we lack and we may need. I mean, how do we start to think about autism and schizophrenia? What would you do next? What questions come up in people's minds? Let's get a little vulnerable here, and as if we don't know, and who would we ask? What are some reasons?
But I'm gonna be super honest, because as somebody who does know, I couldn't get any dang on help for my child, and he went to WVU and had all of the official diagnoses and everything, and those same people were like, he's teetering on this or that. So we're not gonna do the 3-hour long test because God forbid, that would give you some more answers and maybe open up opportunities. That because of my background, and when he became physically aggressive as a teenager, I saw the value in getting him locked up because it was the only way to get resources and assistance that he needed. And I gambled on that, but I knew it was the only way to get him into treatment that might help him.
Okay, so that was your experience. And I remember putting her experience was similar, and this is kind of going in the direction of as they get older and bigger and either harm themselves or others, it becomes less. How do we move away? So now, Jillian, I'm just to hear any other thoughts about other experiences for what they found, what might have worked, maybe different experiences or the same, but what about others? What other suggestions would we have? Again, we want to turn the curve, turn the direction from these experiences. So
one of the hardest things here is like now I've worked in waiver for over 10 years now, and before this I some people may know who I am as soon as I say this, but I came from Chicago. That's where I was born and raised and everything, and I graduated high school in Illinois, and I worked in mental health before I worked in IDD. So, and I worked in like state hospitals, residential settings, places that like are a lot rougher than what our IDD folks are. One of the things that I did notice when I first moved here was the level of psychiatric care that IDD folks were getting was genuinely not good. And I will not, name names or point fingers or anything to some of them, but I mean, there are, I think some of us maybe have read the news in the last 5-10 years and noticed a name or two that lost their medical licenses in West Virginia, who a lot of people at big agencies in the Charleston area were seeing. Personally, I have been there to see a client walk in and a psychiatrist look at them and write a script and walk out in less than 60 seconds. There is a lot of, they need better psychiatric care from the word go, because ultimately when we're talking about the behaviors and things, so like when I hear this kid, the first thing that keeps ringing in my bell is rule out psychiatric, rule out medical before you go to behavioral. And it sounds like the beginning of his issue is a psychiatric issue because he's responding to command hallucinations, right? So if that's the case, that has to be the first thing that has to be addressed before we can even start to talk about data collection and all this other sort of stuff, because all that data collection is not good if the psychiatric issues are what's prevailing first and foremost. Like, he has to be stabilized medically, psychiatrically, before you start addressing maladaptive behaviors in that way. And that's like in West Virginia, at least, that's a pretty basic tenet of our BSP teachings. So my thought, like my first thing is, when you find a good psychiatrist, I send anybody and everybody I have that needs a psychiatrist to that person. Finding a good one is hard.
Finding one at all that does more than, at least in my area, I don't know what it's like in other places, but the ones here see you for maybe 5 minutes, change out meds, and go about their day. And anybody who tests higher than mild mental retardation, medical card doesn't cover therapies for. So you can't even try to get in as an adult with a therapist and have it covered with your medical card.
Well, and I just want to articulate from the psychiatrist's point of view too, that we have to make sure we get all this good information to the psychiatrist. This is really why communication, collaboration is key. I like to think of myself as a good psychiatrist that really wants to do well, but also have to tell you how many times I've seen, especially adult patients, show up on my schedule and no one came with them to tell me what was going on or provide me with any information. And I just saw someone over medicated having side effects, and I had nothing. And if they aren't able to tell you what's going on, or you don't have that data to look at it, it also is really challenging. And so I'm really about the team with this. I mean, I think you're right. If there's a true psychiatric issue, it needs treated. But how are we, how are we communicating that? If I don't see that behavioral data, or I don't get that information, it's really hard to tell in 5 minutes that it's psychiatric. And so I think sometimes our systems are siloed so that we're not all working together. And I think financially our reimbursement system isn't really as structured as it should be to encourage the communication for that type of care. And so um, I go back to sort of the original thing that I think the silos of breaking it into psychiatric or behavioral is helpful to a degree, like academically in our heads, but we all should be sitting in the room together communicating, because I can't do anything with medications, nor can any psychiatrist if they don't get good information. And you're right, we should never medicate things we don't understand. But but what do you do when someone's sitting there? And sometimes the reverse happens, right? You'll see people where I'm saying, I'm stopping this medicine. I'm not writing that because I just see the side effect and I don't know why you're on it. And then people have problems when medicines are stopped because of poor communication. So I mean, it really is messy. But I think, again, this group is reflecting how important all these different pathways are.
I think we all have just made you realize a great business model that you should open and have multiple diagnoses and have teams that I think part of the structural issue with the system is that there's such a concern with keeping our doors open and getting through OFLAC reviews and all of that stuff, or paying the bills, or getting as many people in as we can, that no, there's not somebody at the head saying, this is truly what we're going to do. And we're not going to just filter our clients through, but we're truly going to take the time, which each of our members, and truly look at diagnosing these people properly. And every doctor's appointment I've ever been to with any client has been a 2-minute, what are you here for? This is what I can do for you, and out the door they go. And sometimes they don't even look you in the eye as the staff.
Mark, you have your hand up. Thank you, Jillian. Appreciate that.
I was supposed to say, as far as IDD waiver and people with positive behavior support plans, getting good data from direct care staff has always been an issue. And then getting the data to present to the psychiatrist for med changes is an issue that results from having bad data or not lack of data from the direct care staff. So, the cycling in and out of direct care staff and getting good ones to collect good data for the BSP to present to or to send with the staff to the psychiatric appointment, leads to not having that data that you're looking for to make a good med adjustment. So this is all part of the cycle of having lack of direct care staff to stick around long enough to be your job and get good training and all that. And plus there's just a big lack of qualified and BSPs who are sticking around long enough to get good at their jobs too. So this is a systemic issue.
Good point. Thanks, Mark. Brittany?
I want to kind of spin off of what Mark just said, because on the flip side, we have long-term BSPs at our agency, and we send reports to every psychiatry appointment and to every therapy appointment, and we still cannot get these guys to make the appropriate adjustments, take the time with our clients. A lot of the time that paperwork gets pushed to the side. They don't even look at it. We try to send it in advance of appointments. I know I've gone personally, even at a director level, to certain psychiatric appointments, and we still don't see the changes that these guys need. We are not listened to. We are not, what we bring to the table is just not taken into account. And, a big part of this, this whole thing that we're talking about today is that some of this stuff cannot be treated with just basic behavioral interventions, without the stability and without these guys being psychiatrically stable on the appropriate medications, getting the right diagnoses and whatnot. Sometimes anything that we do is not going to help until that is all taken care of and stable first. So it's very frustrating on our end. We definitely are lacking good resources, and these local psychiatrists here in the Northern Panhandle, we potentially are overloading them with so many people that they just don't have the time to take with our clients.
Good point. Brandon, I'll come to you to finish this out. Oh, and you're on mute. Sorry.
Sorry about that. I was just gonna share something in that same vein, in a personal experience. I think the only thing that helped me in this story was the fact that I did work in a psychiatrist's office, doing mental health before I came to West Virginia. We had a client who ultimately wound up being treated for something that they weren't actually diagnosed with. And one of the things that I'll throw a name. I don't know if anybody ever will wind up coming across this gentleman, but Dr. Alexander Morel was his name. Was a very, very strange but brilliant man. Those things tend to run hand in hand sometimes. Anyways, he used to say that sometimes with some of the mental illnesses, sometimes the only way you can figure out what it is by trying different medications and see what actually works. And I don't know how true that is or isn't. I am not a psychiatrist. That's not my job. But he did point that out, particularly when you have things like, bipolar that doesn't have any of the manic episodes with it, and, treating that one way as opposed to the major depressive disorders. So anyways, the point that I was getting at was, we had somebody who had been diagnosed with the major depressive disorders with psychotic features. And I mean, aggression does not begin to explain what this was. I mean, we're talking like elopement, breaking car windows, fighting the police. I mean, just like, most people are just not equipped to handle this. So on a last ditch, just trying to, pull something out of thin air. Sorry, I almost said something I shouldn't have said there. But trying to pull something out of thin air there, I went back through this client's chart from the charts that we received from Bateman, where he was at some point. And I was just trying to look and find anything that could help. And I came across one exact page in a whole chart, exactly one page that had him diagnosed with bipolar. All the other things had a diagnosis for major depressive disorder. And so I wrote a note, and it was a small thing, and I believe Brittany said, sometimes we will send notes to the psychiatrist appointments and things like that just to try to help out a little bit, especially if we just, we're throwing our hands in the air and we don't know what else to do. And I just wrote a note. And I was like, is there any chance, that he might have bipolar, and that maybe we would try something to treat bipolar? At that time, the psychiatrist, I was not at the appointment. I was told this by the staff who took him. The psychiatrist said, absolutely not. That's not what this is. The client subsequently flipped over the psychiatrist's table in the office and started tearing his office apart. And the psychiatrist then said, well, you know what? What could it hurt to try this? Let's go ahead and try him on lithium. He went on lithium. He has been stable for the last 7 years. That's just my little slice of pie there.
Yep, that's a good example. Thanks for sharing.
Yeah, and Brandon, I might add too, that I think that happens a lot, right? Because there was clearly a depressive episode, we're carrying that, but there really was missing that manic data. I mean, one of the most helpful things too, that when I worked in a facility for IDDD that had both psychosis, is even simple things like tracking appetite and sleep cycles can go a long way to getting the right diagnosis too. So, it's not just tracking the aggressive behaviors. Looking at their energy state or their sleep can really help pick up and or if they're headbanging, can really pick up on subtle things like psychotic symptoms or mood changes that might not meet standards. So even those little things and being that detective that you were can make such a difference. That's a beautiful story.
Well, we are over. I really appreciate the great discussion. Dr. Swagger, Elma, thank you for leading us this session. Very helpful, great discussion. I think everyone's been putting in the chat some comment suggestions. We're going to send some resources that Elma and Dr. Swagger provided or referenced in their slides, as well as the slides. And so thank you very much. Hope you enjoy your afternoon, and we'll see you for session 5 next month.
Leslie, can I ask one question before we go? Any success with getting anybody from the governor's office?
I'm not sure if they're on. The invitations went out shortly after you suggested that.
Okay.
So,
All right, awesome. Thank you.
thank you. Take care, everyone.
Thanks, everyone.